Hey everyone, welcome to our very first episode of our UK Hangout. It's a weekly podcast, and we have a great volunteer, Mike, my amazing co-host from the UK, but living in Canada right now. And I even see in our live studio audience, we've been joined by our friend Alan here in the US in the Midwest. So this should be a really fun discussion today. I'm excited to talk about just care for peripheral artery disease and just the lived experience. It's important that we have these types of hangouts, we make them public so that we can raise the voices of people who are living with PAD to help create the change we want to see, but also to share with others that, you know what, you're not alone, that you're all going through the same thing, and we're all just here to support one another. Right, Mike?
Yeah, yeah, exactly. Yeah, just to help each other get through the each and every day, and just to talk about our journeys. And we don't necessarily really have to talk about PAD on some of the things. We can talk about certain things of what we're doing in our day-to-day lives as well. That's what it's all about. Is getting through every single day the best that you can.
Yep, that's so true. And no matter where you're at in the world, I mean, everyone is just tied together with similar experiences, like our friend Alan. Alan, welcome. Thanks for joining us and helping to, share some of the experiences that we all have on this journey. You can unmute at any time, Alan. This is what it's all about.
Hey guys.
It's about
Mhm.
peer pressure. Hi,
Peer
Alan.
pressure. That's what he does. She throws it to the peanut gallery. We're all good.
I
Yeah,
guess that's
yeah.
exactly. I should have called for the
No,
peanut gallery. That's what I should have done.
I could probably join at another time. I'm at the prosthetist right now, but my journey is I am an amputee from PAD, and half of my foot's gone and my left leg. And part of that journey for me is coming here once about every 3 months to get things checked out, new pads put in, new liners, new this, so I can keep walking. And good news is I've got some other collateral growth in my leg that we just found out about yesterday.
Yeah,
So, which is a
that's
good thing
great
for me.
news.
Keep the one leg I've got so I can keep mobile. That's all I
That's
got.
incredible. And you know what? Mike can attest to this. So we were on this morning in our Collateral Nation podcast with Kevin Morgan, who wrote How to Fight the Crippling Pain of Peripheral Artery Disease. He has PAD himself, but he's also a triathlete at 82 years old, which is incredible. And he was talking about you, Alan, today, saying that these sessions are so valuable because as much as he likes to teach what works for him, he learned so much from you in some of your discussions and you sharing your experience because he's really big on engaging your toes. Well, you don't have any toes on either feet, but you shared with him the fact that you have phantom toes, and when you move your phantom toes, it really comes from your brain, right? People underestimate the power of the brain. You need your brain to tell your toes to move, even if your toes aren't there. He learned from you that you can still move the muscles in your feet um, by engaging your mind and pretending to move your toes, your phantom toes, and you're getting the same benefit from those exercises. He was blown away. He's like, I never thought about that before.
I even discovered that even my amputated leg, I can move my foot, my phantom foot that's not there, and it engages the same muscles that it does on my right leg. It's kind of
Yeah,
interesting.
he was really inspired by you, Alan. He was talking about you. He mentioned you quite a few times, actually, saying that you've noticed you've given him food for thought on things of that he didn't realize that the phantom pains could actually, when you were wiggling your feet and touching your toes and stuff like that, that they could actually still be building collateral. So Kevin was really inspired, and he's done a little bit of research into it as well. So yeah,
Yeah,
he
he did
really
ask
enjoyed
for
talking
a
to you.
he asked for a walking video, which unfortunately I haven't been able to do yet. Like last week was not a good week for me at the going to physical therapy. So hopefully this Friday would be a good day to get a walking video for him on the treadmill so he can see the dynamics where my problems are and what I can correct.
Probably kind of nice to hear, Mike, because your mom is an amputee. Your mom came on, and it was great when you shared your story on our most recent, the Heart of Innovation Save My Piggies episode. And people can find that at youtube.com/the @ the way to my heart. Make sure while you're there, you like this video and subscribe to our channel, like that video too. But I imagine that you hearing this from Alan, that it's something that you could probably go back and share with your mom and go, wow, there's a success story out here with our friend Alan from the US, your mom's in the UK, that you can actually, with your phantom leg, still build collaterals. And while there isn't any research in it, this might be something that a researcher might suddenly come upon this video and go, oh my gosh, that's something we need to research. We need to create evidence around.
Yeah. Sorry, excuse me. My mum always talks about that she can still get phantom pains in a amputated leg. She can still feel her feet, her toes wiggling if she tells her brain to do a certain thing. Obviously, she doesn't want to stand up thinking that she's got a leg still there, because she'll end up on the floor.
Oh yeah, we hear that all the time. That's the hardest part.
Yeah, and even when she was here, she was in Canada a few weeks ago visiting me, and there was something that happened with one of the dogs, and she went to go and grab the dog, and she didn't even realize, and she just ended up on her backside on the floor, ended up with a big bruise on her backside. So yeah, going forward, when she does talk to me about phantom pains and stuff, I can put this to her and say, even though you're getting the phantom pains, even though you're going to try and walk, you're still building collaterals in your leg that's not there, and you see on what's left of your leg, especially in the thigh and in the knee. That she's still got, even though she's not got the leg, she's still going to be building collaterals when she's walking on a prosthetic. So it's all good. It's all very good.
And Alan just got called into his prosthesis appointment. So it's just you and me. If you're watching on YouTube, go ahead and engage. Let us know you're there and you're watching, and comment and ask questions and share your experiences as well. You can also join our live studio audience at any point as we kick off this series on a weekly basis. You can email info@padhelp.org, and we will get you on our email list so you can have the link each week so you can join our live studio audience, but you can also subscribe to our channel and go ahead and just watch via YouTube as well, anonymously, and be a fly on the wall. But you can also engage in the comment section, because we love hearing from you. It's all about our journey together and how we can help one another. And we don't know how we can help you until you tell us how we can help you. But it's great because, Mike, you join us, every week. Um, and one of the reasons that you do join us every week is because in the UK, you don't get as much guidance as you need. And I don't think that there's any way that any healthcare system can guide you 24/7, as so many people need with having PAD. PAD is not a, once every 6 weeks, once every 3 months, once every 6 months type of deal, where you go see a consultant. It's literally 24/7. And especially when you first get a diagnosis, it's scary. And you can't even get in to see a consultant in the UK sometimes, if at all, for 3, 6, maybe even 12 months, right?
Yeah, mine's still on a 12-month wait at the moment. My referral went in January, and I'm still yet to see a vascular consultant. As you can, if people have seen my video that I did with Save My Piggies a couple of weeks ago, yeah, my referral went in January, and I had to take myself into an A&E department because I was really struggling, and they referred me to a vascular hot clinic, and that's the only way that I was actually able to see a vascular doctor at the time. So yeah, it's a long way. It's a long struggle, and you're just kind of left to live your life in fear, I suppose, until you do see somebody. I've been fortunate as well with a lot of people to have found yourself, Kim, and found these groups that we're in, to get a little bit of reassurance and a little bit of motivation and a bit of inspiration to not lie on the couch every day, not dwell on the situation that you're in, because the NHS, it's struggling. And no criticism for the NHS, because I used to work for them myself, and I love the doctors and the nurses that I used to work with. I've got so much admiration for what we were all doing, But I find that they still put a lot of it down to the pandemic. They still say that these long waiting queues and these long waiting times and stuff are down to the pandemic, which is understandable. You know, they're still trying to catch up with all the patients that they couldn't see at the time. And it's the same for cancer patients. It's the same for people with gastro problems, people with neurological problems. Everybody's on a waiting list still, and it's down to the pandemic. It really is. So it's just, I'm just so thankful for yourself, Kim and Josh, and everybody on the group that, you know, all the support that I get. It's been amazing. So, hi, Alan.
Yeah. Hi, Alan. Alan
Hey,
is
I'm
back.
back.
He was in his prosthesis appointment. That was a very quick appointment, Alan.
No, I just needed a little bit of a tune-up, some padding in places where I thought I needed it, and it's a whole new feeling. We're trying to get rid of this thing called pistoning that goes up and down when you walk.
Okay.
The after so far, the prosthetic moves up and down, and it can cause sores and all sorts of different things you don't want, and it causes infections, stuff like that. So you kind of have to pay attention. Just put a pad here, put a pad there, and it can stop. And so far, so good. The first 3 minutes.
But it's a constant process, right? Some
Yep.
physicians think that, and I'm sure Mike can attest to this too with his mom having, had the amputation, is that some of the doctors think that the amputation is a permanent solution that will get you back on your feet and get you going again. But it almost feels to me in working with and being on the journey with you, Alan, through this entire process from amputation through prosthetic and getting back walking and such again, that there's still a revolving door of appointments and more
Oh,
appointments and
good.
more appointments, because
Yep.
prosthetic is not a one time, one size fits all answer, one and done.
No. Um, Usually in the beginning, it was about every 2 weeks. Now it's about every 3 months. So once you get a prosthetic and you get something that works, things have a tendency to wear out. The padding, the straps. I have something called an adjustable. It's not one where it's all solid all the way around. So there's adjustable straps on it that have to be repositioned. Some of the hardware breaks down, and it just needs a tune-up. So every 3 months, I come see them. I get new liners, and off I go.
And Mike, for your mom, is it as easy as that? It seems it probably isn't, that easy, Alan, to get in right away to see the prosthesis. But I'm wondering, like, for Mike's mom, what that's like for her as well, to have how often can she get the tune up? Does she have access to these, multiple appointments on a consistent basis with her prosthesis?
I think I think my mum's quite pushy when it comes to, they call it the limb centre where they go. I think because she's been going there for so long now with her having her amputation. Sorry, excuse me, frog in my throat. With her having her amputation over 12 years ago, I think because she's got such a good rapport with all the staff there and the nurses that work at the limb centre, that when she rings up and says that she needs something, they kind of get her in straight away. So I think that she has like
That's
a
good.
good continuation of care when it comes to the limb centre. I think that if she was to have a problem with her other foot or her other leg, which she hasn't, I think that
Thank
she'd
goodness.
probably have to go to a GP again, and it'd probably be another referral, or maybe one of the nurses at the limb centre could get her in to see a vascular doctor. I don't know. But I'm presuming that it'd be another referral again, and it'd probably just be another waiting game, really. But
I think the
with a
NHS
thing,
is kind of like I think the NHS is kind of like our HMO programs here in the United States, where you always need to go to the GP. Although, if you maintain the same insurance, even if it is an HMO, once you are seen by a vascular doctor, you're in their system. They don't discharge you in a sense back to the GP. They still let you go to the next appointment. And if the next appointment you go to the vascular and they say, hey, we can't do anything for you right now. Thanks for checking in. We'll see you in a year. In the meantime, talk to your GP about medical management. Talk to your GP about, or primary care physician is what they're known as here in the States. Talk to them about managing your medicine, and talk to them about getting in with a dietitian and physical therapist for gait training, and supervised exercise therapy program for walking as well.
Yeah, she does have an occupational therapist she's under at the limb centre as well. They get her up and walking. They monitor how she does on her leg. But like you say, I think when it comes to the other things like dietitian and stuff, she'd probably just have to go back through a GP for things like that.
Is that
It's
something
very
that they
hard in
readily
England. It's
do?
very hard situation. Sorry.
Is that something they are forthcoming about, to say, because they're not here, they don't say, okay, we're going to, you have peripheral artery disease, you have diabetes, we're going to refer you to a dietitian. They don't necessarily
No.
do that. You have to ask for it. And if you ask for it, they're more than happy to make a referral. Is that the case over in the NHS as well?
Yes, yeah. They're more than happy to do stuff like that if you go to your GP with problems like that. But I'm not too sure how my mum. I don't know whether I think she's been discharged from the vascular surgeon. But on the knowledge that if anything happens in the future, then she's to get straight in touch with them. I think that I'm not too sure how it works, to be honest.
It's interesting because that might be something that could change over the course of the next 5 years or so, because they have some studies that they're working on in the NHS. One of the things I love about the NHS is the collaborative nature of them, and all the doctors coming together and aware of what everyone else is doing when it comes to trials, and the funding that's going into the trials. And there are a lot of trials. I think there are about a half dozen to a dozen trials going on, and a couple of them that we're looking at, well, one there in the NHS, and another one which the Global PAD Association is participating in Australia. We are working with Dr. Shannon Thomas there, and one of his fellows, whose first name is Thomas. We're working with them on the same study, it seems, that's happening in the NHS, where they want to see if post-procedure, so if they've had a procedure, whether it's a revascularization where they open up and restore the blood flow manually, or if they amputate, that someone that is in advanced stage PAD, if not only regular follow-up appointments will help, but also follow-up appointments coupled with an ultrasound at every one of these follow-up appointments, if that's going to make a difference in preventative care. Because why are we waiting? Why are you discharged from a vascular surgeon in the UK if you've already been amputated? So obviously at that point with her leg, the GP wasn't enough. So how
Yeah.
do we prevent having the same issue happening to her other leg? Well, what they're looking at is, do we have regular ultrasounds for these people who are at greatest risk of amputation, which would include your mom? And that's something, as Alan
Mm.
will attest to, here in the United States, you don't get discharged from a vascular specialist. Once you're with a vascular specialist, they maintain you under their care, where
It's
usually, right, Alan, it's every
every
year.
3 months. I have to
And
go
for
in.
someone like you, it's every three months.
Yep, I get an ultrasound of both sides all the way down to the foot, and I see the doctor that same day, right after
Yeah.
right after, and it's convenient because both of them have in-office ultrasounds and access to hospital care immediately if need be. I think a
And
lot of it also here in the United States has to do with the type of insurance you have. I'm just really fortunate with what I have, and um, I get in a lot of doors that way, I believe, and I think sometimes they're closed for other people. And it's unfortunate that it's become big business here in the United States, where I think everybody needs some basic care that can't get it. And
yeah,
as
and that's where,
a lot of my PAD friends I hear just can't get to the level of care that they need to be.
And I think that here it's literally about advocacy. So they need to
Yes.
learn how to work the system and advocate for themselves, because every system can be worked through. It's just you have to work at it.
Well,
And that's
you
really,
have to push.
you have to
You have to
push.
really
You have to be
push.
that little pest. You have to be that mosquito.
And if you
Keep stinging.
hit a brick wall, then you call Kim, and then
And then you call
then the
him.
doctors get scared.
Yeah, that's the same as me. You know, a couple of months ago, I was really fretting about what was going to happen, and I even got to the point of when I was going to go back to the UK in January that I'd actually booked myself a private vascular consultation in a private clinic. I was willing to pay for this. And then I got in touch with Kim, and Kim put me in touch with a great doctor in the UK who gave me a phone call at the beginning
On a
of
Saturday, on Easter
on a
weekend.
Saturday over Easter weekend as well. And I give him my NHS number, Alan, and he looked into all my notes, and he was just like, right, this is how it is. I need to really reassure you and put you back on the right track, like you do yourself, Alan, many times. Um, and it just kind of reassured me that I didn't have to go to that private consultation. I didn't have to be out of pocket any money with any money. I can wait for my referral just by what that doctor said to me, and especially as well after speaking to Dr. Phillips a couple of weeks ago on the call when we did Save My Piggies.
Honestly,
I mean,
that's amazing. You
he
got
was
that.
phenomenal. He was phenomenal.
Yep.
You know, I've spoke to him once or twice through WhatsApp now, and he's just reassuring me all the time and making sure that I'm in this right kind of headspace now to move forward and
If
be
not, we
able
just take
to.
a big baseball bat, slug you one, and put you back on track.
Yeah, and I bet you'd love to do that a couple of
Oh
times,
yeah,
Alan.
every now and then.
Oh yeah.
Sometimes, we all need that virtual smack and, across the head to realize that, we're gonna be okay. We're gonna be
Yeah.
okay. We're all here for each other, right?
Yep, everybody gets in their own headspace, and I call it stinking thinking, and everybody needs to be told, okay, what are you going to do about that for yourself to get you back on track to where you need to be?
Yep.
Yeah.
And Mike, Josh, our amazing YouTube producer and friend, wants to have you describe for especially the United States audience what it means to be discharged from vascular, like your mom was discharged from vascular back to her general practitioner, her GP or primary care.
Hmm. I don't know in what kind of way. I mean, discharge it means that they've not finished their care with you, but they have for the time being, and that they feel like that your general practitioner or your physician is able to monitor you
I think
from
the
that
question
point
would be,
onward.
does she have to go back to the beginning all over again?
And I
Right.
think that's what it is. You go back
Do you
to
go
the
back
beginning
to the
with your
beginning?
GP,
Yeah, if
and
she
then
had
you
a
have to
problem
be
And is it
referred
that
again.
difficult for her to get back in?
yeah, the vascular doctor has said that, he's willing to see her again in the future if she does have problems with her other leg, but it will be a referral to go through the GP. So
Hmm.
theoretically, yes, she will
So it's
probably go
starting
back
all
to.
over again.
I think
Yeah.
it probably would, but
Hmm.
because she's already had an amputation, she's already on the radar. So she probably wouldn't wait for 6 to 12 months to be seen. They would probably bump my mum up. They'd
Yeah.
probably see her a lot quicker, knowing the
Yeah.
history that she's got. It wouldn't
But
be
it's
a
still one
complete.
of those, versus Alan can go straight to his vascular and say, hey, I have a problem. I need to be seen tomorrow. Versus your mom, it would be, I have a problem. She would be seen by the GP first to make sure what the problem is and if it's right to go to vascular. And then she would have to get the referral sent to vascular, and then she would
Hmm.
get the appointment. And the only way around that is to
Yeah,
go through the
Wow.
emergency department, which is the AE.
And in
yeah.
that point, in that
So,
length of time, I could have lost a leg taking that
yeah,
long,
yeah,
easily,
and
quickly.
that's why the accident and emergency departments in England are so overrun as well, because the doctors, the GPs will give people letters to say, right, well, if they can't see you now, well, here's a letter. I want you to go to the accident and emergency, and there's going to be a specialist doctor that's going to be there waiting for you. And it's just not the case. You know, some people come into the A&E department, they've got these letters off the doctors, they come to the front desk and they say, this specialist doctor is supposed to be here waiting for me to come in. Now, what they're not told by the GP is that specialist doctor knows that you're arriving. He knows that they're aware that you're going to turn up in the A&E department, but you could be sat in the A&E department for 6, 8, 10 hours waiting for that doctor to come down into the
Yeah.
department to see you. And then they make the decision whether you're going to be admitted or whether they're going to do blood tests, whether, you know, the accident and emergency would not normally do an ECG and probably do blood tests in the meantime, just so that everything's in place for the doctor when they come to see you. But we've had people kicking off in the waiting rooms in A&E because
Yeah.
they're under the impression that the doctors are going to be there waiting for them when they arrive. It's just not the case. It's that doctor is aware that you're making your way there, but they're not going to be waiting in the back of A&E waiting for a certain patient. Not when they've got a ward full of 28 patients upstairs that they've got to do a ward round, they've got to administer drugs, they've got to do prescriptions, they've got to monitor people's legs, and they're not going to say, oh, we'll put all that on hold because I've got this one patient coming into A&E. They will wait until they've done all their work upstairs, until they've got a free half an hour, 45 minutes, and then they'll come down to the A&E department and see you. It's not like that.
It's
And
like
so
for
are you
me,
seeing?
I'm able to call my doctor. They actually, a couple of them give me their cell phone numbers and say, hey, my leg is going down. They'll get me right into a room at the hospital. I could skip right over emergency.
Yeah, no, they don't
And
do
that's
that.
what's
Usually.
incredible.
Yeah.
Because there are situations such as with Alan, and I know that they're few and far between. I find that there are more and more these days for some reason, and I'm not going to speculate, but we do see coagulability, people who not only have the rock hard atherosclerosis, the calcium in the arteries, but it's just on top of that, they have clotting issues for a variety of different reasons. And we're seeing that more and more than ever. And in those situations, it can become acute. And I know we've had several situations where Alan, even though Alan's on anticoagulants, you're on maximum, and he still has some acute clotting situations. And in those moments, we need a bed right now. I mean, it becomes an emergency. And what's great is for his insurance is we don't send him straight through the emergency, which is a lot more costly on insurance. We're able to go straight to the doctor. The doctor is able to say, hey, I need a bed for this patient, and we're going to run him through that way. And it's, of less cost and, less time, because you could literally have 12 hours in a situation like this. If you have an acute clotting situation, you could the tissue starting to degrade immediately, and you could lose that leg can go dead in 12 hours. I mean, it can go quickly without
It's
oxygen.
happened to me.
So
That's the left
it
leg.
has.
You
Yep.
can
And
do
you
that. I mean, if you're willing to pay private, if you're willing to pay the private doctors for the consultation, you can ring your private consultant and say, you know, this is happening. But a lot of the private doctors as well work with the NHS. So if you go in
yeah.
and pay for a private and see a private doctor, I'd say probably 8 out of 10 times they put you on their list. If they weren't that concerned, they put you on their list to be seen through the NHS. So
And
they
the
kind
good
of,
thing is,
I think the concern is you hear socialized medicine in this country. Everybody, like Bernie Sanders, worries a person like me. Because where does that go? Where does that leave a person like me? Because it becomes in a situation like Mike and his mom are in.
yeah.
Yeah, and that's scary.
There's a certain amount, and what I think people don't understand here in the US, there is free healthcare. I know here in California, even the immigrants get free healthcare. You get free healthcare. If that sucks, you have to go through the emergency room. But anyone who goes into an emergency room, whether you have insurance or not, you get care. You are seen. You are not turned away. So that's really good. Once you hit a certain age, also you get a certain amount of Medicare. And for, additional costs, you can get, additional supplements. You can also get Medicare Advantage plans. But the problem with the Medicare Advantage plans right now is that Robert F. Kennedy Jr., who's the head of the health secretary, he made a deal with all of these Medicare Advantage plans to say, you guys need to start getting control of these pre-authorizations and start limiting those, minimizing those. You can't just have an algorithm that's just, the default that you're going to delay or deny these, life and limb-saving diagnostics and care. So what they're doing now, and they're like, sure, we'll agree to that. We'll just drop those doctors that are doing the limb-saving procedures. And so that's really a serious problem that we're having here in the United States right now, which is why it's really good that, Alan, you do have good insurance. We do need to democratize, access, but we don't want to minimize care and create standards that are below what patients actually need, right? You need to be able to see a vascular specialist sooner than 12 months to get you on track with your PAD. So you're diagnosed. You do need to meet with a vascular doctor, there's so much more schooling that a vascular surgeon has to go through versus a GP. Of course, they're going to have
Yeah.
greater information and a better assessment for you than just a GP. GPs are great. They can pretty much recognize a little bit of everything. But when it comes to a diagnosis for a serious ailment such as PAD, you need to get that consult sooner than later with an actual list of things that you can do. You need to be classified right away. What Rutherford class are you in? Are you in the early stage intermittent claudication phase, which is where you're at, Mike, right?
Yeah.
Where you
Yeah.
walk, you get claudication or those leg cramps, but when you rest, it feels better. Some days are better than others, but that's still intermittent claudication. The next phase is lifestyle limiting claudication, right? And that's where maybe it affects your job. It affects you go to the store. You can't really walk down the supermarket aisle without having to stop and rest, maybe even getting on one of those motorized carts. And even when you try a walking program for 3 months where you're really trying to push through that claudication, it just doesn't seem to improve your symptoms. And then you have, and it advances, right, to the advanced stage critical limb ischemia, where those Charlie horses, those wretched Charlie horses, actually wake you up out of a sound sleep. And then beyond that, you end up with a wound that won't heal on your foot because you're not getting circulation down to the foot. So the nutrients, the oxygen to heal that wound are not getting there. And that becomes where Alan was and is still in that phase where, even though he's not actively in critical limb ischemia right now, he will always be, in a sense, in critical limb threatening ischemia. He will always be at risk at a moment's notice. And so that's where I really think it's important for you to see everyone in the NHS to be able, once diagnosed, to see a vascular doctor sooner rather than later, get the proper classification and the things that you can do right then and there to start improving your prognosis. Get you referred to a supervised exercise therapy program or a structured walking program. Get referred to a dietitian. Get referred to an endocrinologist to get the diabetes under control. Get referred to a smoking cessation program. But get those now, because as soon as you went to A&E, right, Mike, and you
Yeah.
had that vascular consultation, you immediately started taking your health into your own hands. You quit smoking, you started eating
Oh,
better, and you started walking.
yeah. With as soon as I walked out of the appointment, after I went to the hot clinic with the doctor, he just literally said, he told me that I needed to change my diet, which I already had. To some amount, I'd already started changing my diet because I started feeling these symptoms last year. So I started Googling things in November. So I kind of had a feeling that this was what it was. And obviously, because of my mum's history as well. So when I went to go and see him, I'd already changed my diet, say 50%. I was eating a lot more fish and a lot more vegetables anyway. But just before I went into that appointment, I smoked a couple of cigarettes on my way to the appointment, and as soon as I came out of there, and because the doctor did say to me, "You need to give up smoking right now. You really need to give up
Period.
smoking."
Mhm.
So you know, it's one of the things that I've done. I exercise a lot more now. I was doing a lot of walking on the treadmill anyway before, but yeah, it's getting that reassurance that you need.
Yeah.
Definitely, and it's if I hadn't have gone to see that doctor, if I hadn't have gone to A&E when I did, I'd still be struggling now. I'd still be
Yeah.
wondering what was happening.
So again,
Um,
that power of being able to see a vascular consultant sooner rather than later, and being able to put your mind at ease,
yeah,
and to
It's,
give
it
you
gets,
those things,
it
right?
gets to be getting back into that headspace. If it's just as important to remain positive and not let yourself go there. And if you do, seek professional help immediately. You can become very complacent very quickly, and things turn south for with your health, and you don't want that to happen. This
mm.
this disease can be drag you into a depression that you don't want to go there.
Oh,
And
100%. And it's like Kevin Morgan was saying this morning on the chat. He was saying it's a process of like grief. So
yeah,
Yep.
you go through the stages of grief. Um, Acceptance being one of them, emotional, depression. I think they say it's the 6 or 7 stages of grief that you go through, I think, and acceptance being one of the last ones.
They say it's
And
like a
it really
death.
is.
It's like a
Yeah,
death with losing a leg anyway. It took a good 3 months
yeah.
to get back on board and fight.
yeah. You have to get past that. And as Kevin said this morning in our Collateral Nation podcast, to you have to get to a point where you leave the past behind, accept where you are, but it is a process of getting there. And some days you go back and you go through the process again, but you have to allow yourself to go through the process, right? It's it's a never ending, story. And that's why it is really important to, um, I think that all patients that get diagnosed with a chronic illness or anything should have regularly scheduled appointments with some sort of counselor. It doesn't have to be a psychologist or psychiatrist or anything like that, but just someone that can help you reframe what you're acknowledge and what you're experiencing, and be able to help you reframe it so that you can move forward. Because it's so easy to, for example, we had our friend Marie on, and even you were saying, Mike, this morning in the Collateral Nation, that um, when you get into those moments and you kind of backtrack and you end up kind of falling, going backwards, taking a few steps back, it's really easy to lose that motivation, right? To walk, and you gotta walk, you gotta move, you move it or lose it.
Sorry for interrupting. I keep seeing Alan pointing, and I know that he's pointing at me. Alan,
Oh,
Alan's like my counselor. He's like my mentor. I know that if I have any problems, I can just text Alan, and he really reassures me. But for me, it's like, no pun intended here, but it's like I've got one leg shorter than the other, and I go round in circles. I'm kind of trying to get that leg where I can move forward with it, but it tends to keep bringing me round in a circle. So there's some days where I'll be really, really down, really,
On the
really
bad
depressed.
days, he is more like the Three Stooges. Remember Curly going in the circle like that? That's him.
That's me.
And that's when I get a
glad
phone
you could
call.
laugh about it.
Yeah.
Good to have a sense of humor about it. And it's good to be honest about it, because you know what? It is what it is, right? And you see it, you're like, okay. And Joshua, our YouTube producer, had put into the chat here okay, so I guess it's 5 stages of grief: denial, anger, bargaining. I don't know what the bargaining part of it is, depression, and then acceptance. And so I don't know if those are in order. I have no idea, but that's
Yeah, I
those
think
are
they
the
are.
different stages. But you can go back through them. It doesn't mean that just because you get to acceptance, you're
Mm-mm.
not going to fall back into denial, instead, as well.
Yeah, they're
Yeah,
not
Yes.
planted in sequence like that. They one will escalate, and you reach a peak, and you can fall right back 2 stages back the other way. It's a vicious cycle. It can be, and even spiritual help or
Yeah.
a little bit of guidance can be a good thing too.
Yeah, I think so. I think no matter where you are, I mean, as Kevin even said this morning, Kevin is not really spiritual, but he's more pragmatic. But by the same token, he still believes there is some sort of universal energetic power or something. And so whatever it is, there is a power of the mind, a power of the mindset, and we do have some control. We can try to have, the control. We can have control of what we think. I know that's even a scary thought, because when you have those thoughts and you're like, oh my gosh, I'm falling into a depression. I can't do this. I can't do this. I can't do this. And then you're like, I can't control it. I don't know. Can I really control it? And it makes you fall further, the fact that you're not controlling those thoughts. But you have to take a deep breath and you have to say, okay, that's where I'm at right now. I know I can control it. I have those things. I see you guys running through my mind. I don't like those thoughts. They don't make me feel good. They're there. I see you, but I prefer to feel better. And when I'm ready to feel better, I know I can think a better thought, right?
I sometimes, I speak to Geordie about it all the time. And when I'm having a bad day, the one question that I always have, which is an unanswered question, never get the answer for it, is why me? Why has it happened to me? I think to myself, I've done everything good in life. I've never been a bad child to my parents. Well, occasionally, I've grown up with two. I've grown up with two older sisters. My sisters are like my best friends. We get on so well. I've literally done nothing in life to hurt anybody, and I'm just like, why has this happened to me? Why is, if there is a God, if there is a greater life out there, then why did he choose me? And somebody said to me a couple of weeks ago, I think it was Beth on the other group, is um, he always picks the strongest ones. He picks the ones that he knows that will be able to deal with it.
Yeah.
That's what I was just gonna say. Boy, have I changed over the past 3 years that
Yeah.
Kim has known me. I've gotten stronger. I've become more patient.
Yeah.
Um, Little thing like having to stay in the hospital and have an angiogram now doesn't scare me. I know they can get through it.
Hmm.
And, um, even the thought, okay, if I even said to Kim before, if I lose my other leg, that's it, I'm done, you know, but I know me, I'm going to fight through it and still,
Yeah.
keep on going. And that's just the spot you have to get to. You have to live your life, not the disease. Once you live the disease and you stay there, it's a spiral right off the road. That's real hard to get back on.
Hmm.
Yeah.
So can I just ask, what's the difference between an angiogram and an angioplasty? Is angiogram where they just do the scan?
Do
You
you
want
want
to take it,
to,
or
do
you
you
want me
want
to
to take?
take it?
I would love for you to take it. You've learned a
Sure.
lot
An
through working with
angiogram
us.
is where they actually go in the groin or your wrist, and they put in a catheter. Then they can slip wires and different things through, plus this thing called dye. And the dye is a little, not radioactive, I don't know, it's an isotope that actually they could take x-rays, and they can see the blood flow and where it is. So they can see the blockages, they can see clots, they can see all collaterals, everything.
Okay.
I call it getting up close and personal, because the doctor that's doing it knows right where to go to. Angioplasty is the following: if I have a blockage that they could get a balloon into, and then they pump it up with air, it pushes the
Hmm.
plaque and all the gunk to the side. If you need, again, this is part of the angioplasty, is they may take something called a, oops, help, I lost my thought. They have different drills, they have
Yeah.
lasers,
Atherectomy devices.
arthrectomy, where they go in and they'll clean out that area first. Then the balloon goes in and they push it aside. Then they'll put in a stent sometimes. So
Okay.
that's how they open things up.
Yeah. And you can
What
have
say?
a CAT scan. So you can have a
Hmm.
CT angiogram, a CAT scan that they pump in the dye. coupled with the CT. So that's called a CT angiogram. And a lot of the doctors, most of the time, I would say 99.9% of the time, they do that in the UK prior to any full angiogram. So there are two different also types of general angiograms that you can get. You can have a diagnostic angiogram where they get a better idea under, where they pump in the contrast fluid and they're under the x-ray. The contrast fluid, as Alan said, it just lights up your vessels underneath the x-ray, makes it so that you can actually see them and you can see where the collateral vessels are and such. If they do that, and sometimes it's actually, better than just a CT angiogram. They can see things a little bit more clear to your toes, is what I'm told by the doctors that do them. But a lot of times, if they do a diagnostic angiogram, they're going into, quote, stage where they are able to get a really clear idea of what they want to do once they go in, so they can make sure they have the right tools, the right sizes of balloons, right sizes of stents if they need them, the right atherectomy devices, which are the ones that roto-root, whether it's laser, whether it's an electric sander that rotates, or a drill, or even have one called lithotripsy. And it works different than atherectomy. That one just cracks the plaque. It's almost like what they would use. It's the same type of technology, audio waves, that they would use to break up a kidney stone. And they now use it to crack the plaque inside your arteries as well. It's great for calcium, and they're even using it in the heart. It's that safe that they're able to use it to crack the plaque in the coronary arteries as well. Now, if they decide that they are going to do a full angiogram with treatment, then they'll let you know that as well. And they'll go in and they'll use those devices, such as the angioplasty, such as the atherectomy, or a lithotripsy device, plus maybe a stent. They're using fewer and fewer stents. The whole idea is leaving nothing behind, cause less trauma. There's even a retractable stent that they now use. And it was first to get CE mark over there in the UK, and they just got FDA clearance as well, and it's starting to roll out here. But it's a retractable stent to be used below the knee, in the below the knee vessels. But here in
So
the
cool
US,
for somebody like me.
I mean, it would be really helpful, because they really don't like to leave your body. If you leave something behind, there is going to be an even greater healing response in the body. Just like you scratch yourself and then you get scar tissue, you get that in the arteries as well. And when you go into the vessel, no matter what, it's the level of trauma, right, that's going to cause an even greater healing response to your body and more scar tissue building up. So they try to tiptoe in as much as possible, taking a less is more approach. You really want a doctor that is going to take a less is more approach and not tell you that they are going to go in and stent unless it's in the iliac arteries, the aorta, or the heart, or even the carotids. Those typically they'll tell you are going to get a stent, and they're more durable. But in the rest of the leg, it's a red flag, in my opinion, that they're going to say you are 100% going to get a stent, because what you really want is a doctor to say, you know what, I'm going to go in with a less is more approach, because the only reason to have a procedure is to get you walking. So whatever is limiting your ability to walk, that's what they just need to do, just enough, get you that much blood flow to get you, to be able to sleep at night, to be able to heal a wound. And if you have lifestyle limiting claudication, where you've tried walking and it's just not, doing anything for you over 3 months, and you've really pushed it. If you're not getting any better, then they can actually just go in, tiptoe in, kiss the plaque with a little balloon, and just get you that much more blood flow to ease your pain so that you can walk. But none of these procedures are durable. You always want to make sure there's a contingency plan. And that's why we say that your best frontline treatment is to walk, because then there's always the contingency plan. There's always a minimally invasive procedure they can try. And then if you have the right doctor that makes sure that you don't burn any bridges for a potential bypass, then you're just going to keep having potential contingency plans to keep you on your feet as long as you can. But those procedures are only for when you can't walk, it's not improving, and even after you have the procedure, you got to walk, walk, walk to maintain it, because it's not a matter of if it's going to block up again, it's a matter of when. And the whole
Mm.
goal is to be able to get enough blood flow so that you can build those collateral vessels in your legs, which is what you're doing every single day. And which is what, Alan was talking about in the beginning, that even with his prosthetic, he was able to, because he moves, he's been able to grow collateral vessels to maintain his leg.
I think there's 5 different blockages in my lower leg that are all collaterals.
Wow.
Yeah. So
That is,
when I
you have
say
the
you're going to be
collaterals around
fine,
them. Yeah.
sir, you're going to be fine. Just keep doing what you're doing. You're a rock star with PAD.
I'm
Yeah.
trying. Like I
Yep.
said to Kim before, I am trying. I'm trying my best. I
Yep.
hope I am.
You're doing everything you can.
I have to say also, I wanted to say in the UK that if you do have a wound, we were told by Dr. Thanos Saratzis out of Leicester. He's an incredible PAD researcher, so many different research trials. Make sure to go to padtrials.org for all of the trials that are happening in the UK. We're adding more and more each day. So really important that you go and check that out. But he was telling us that there is a rule in the UK that says if you do have a wound on your foot that's not healing, you have to get seen. I think it was within 24 hours with a treatment within 5 days or something like that. But it is marked urgent. You have to let your GP know and say, hey, I have a wound on my foot that won't heal. My foot is cold. I need to be seen. That it is policy over there to get someone who has a wound that is not healing to be seen urgently.
Mm.
And that's
I
the
think,
NHS rules.
yeah. Can I just ask, just backtrack a little bit? What's rotor rooting?
So rotor rooting is that's the atherectomy devices. Those are the plaque removal devices. You have the lasers, you have the drills, you have directional, orbital, rotational devices, laser devices that are all out there, including the rotational sander. We had a patient that was on, and he watches a lot of our videos. Patrick, that is in our this week's The Heart of Innovation, Save My Piggies podcast. You could find it youtube.com/the @ the way to my heart. And he was talking about how when he did his research, he actually found the Diamondback 360 device, which is the rotational sander that has been around for a long time. And even Dr. Phillips, who is the co-host of that show with me, he uses it a lot for rock hard calcium just to sand it down. It was even used in my dad's LAD, the Widowmaker, the big artery, your main artery there. And it was used just to sand down the plaque just a little bit to make it more amenable for a balloon to go in there and inflate with less pressure to push the rest of the plaque aside to create a greater channel. They call it, with that luminal gain, true lumen. Your lumen is the main part of your vessel. And so they just want, luminal gain, a little bit more of a channel for the blood to get through. And so, and then you put in the balloon, and you can just stretch that artery a little bit more.
And here's
Yeah.
the fun part
Okay.
of that. Rotor
Thank you.
rooting is actually a company in the United States, and we use it as a loose
Roto-Rooter,
term.
yes.
Doing this, rotor rooter actually cleans out drains
Pipes, yeah,
to
I
the
thought it
sewer.
was. It's just because I've heard that before. Because Geordie's mentioned it before now about rotor. Why can't they just go in and rotor root it? And then when I
Yes,
seen
they
that
can.
rotor rooting was actually a thing, it was like, oh right, okay, so it's like plumber. It's like
Yep,
Yeah.
it's my big joke
going
is,
and cleaning
is
the
drinking
pipe.
liquid plumber. Maybe that'll work. You know,
Oh, don't do that at home. So that is really funny. So that is really funny. So you guys in the UK, you didn't know, and I'm worried. Tracy, hello, Tracy. Tracy joined. You might have seen me wave a little bit ago, but it was because Tracy joined our live studio audience. Do you guys don't have the phrase roto rooting? Do you there? Do you know what a roto rooter is?
Not really. No, as obviously
Yeah.
they do it in probably vascular will know what you're
Wow.
talking about. But
The
yeah,
power of branding for that plumbing company. Good job.
Right.
That's fantastic. I mean, that's great because you're in the US. I say, hey, they're just going to go in and do a little roto rooting, and even the doctors. And I don't like it when the doctors use that with the patients because I really think that a more educated patient
It's
is a more compliant patient, a less anxious patient. And if you go in there and you say, okay, we're going to break it down for you first, and we're going to say, we're going to go in there and do a little roto rooting because you can relate to that terminology, but let's, meet you where you are. And then now let's guide you where we want you to be, which is to understand the terminology a little bit better. So we're going to do roto rooting. And what that means in clinical terms is we're going to go in and let's say we're going to use a laser to ablate the plaque and just dissolve some of the plaque that's in that artery, right? That takes
yeah,
you to a whole other level. Okay, you're going to use the laser, and then what happens? Well, that's going to help us to create a channel. And maybe if we do a couple passes with that laser, we can create an even larger channel. And then we're going to slip in a balloon. Now that the plaque is maybe a little bit more amenable, maybe a little more flexible or whatever it might be, then we're going to stretch the vessel a little bit with the balloon to create an even larger channel. And
this
that it helps you to understand the whole procedure a little bit
this is
better.
this is the stuff I geek out on because it's so interesting to see what's coming up. And text my doc. Did you know about this? Yes, Alan, we knew about that.
Well,
Thought I found
especially
something
your
new.
doctors. I don't
Yeah.
think there's anything your doctors don't know about,
No,
Alan.
that's true. I just kind of stopped that after about the first year, because it was just so cool finding out what these things did and how they work and how they could benefit me. And yeah, that's kind of my PAD geekness, if anything.
so how are you getting on, Tracy?
I'm okay. I emailed the senior today because
Dr.
do you
Nasir
remember I
Ahmad,
told you? Yeah, do you remember I slipped? Do you remember I told you that I slipped
you
Yeah,
did.
3 weeks
That's
ago?
right.
I banged my head, and well, I'm starting to get pain in my left calf when I walk. So I just
wow.
want to know if a slip or a bang can cause blockages.
Well, it doesn't necessarily cause blockages, but if you're not moving, and there's a lot that goes into it. If you're someone who clots a lot and you're not moving, that could end up where you could end up locked up again. And so it's always worth getting checked to just make sure that was it just part of the fall or is there something. So getting a vascular evaluation, getting that Doppler ultrasound is always important when you are in the advanced stages of PAD, but also it's really important to make sure that you are mitigating those risk factors and diet, smoking cessation. Every time you restart smoking, if that's the case, you end up where the oxygen can't get down to where it needs to be. Your vessels start spasming, and that can create the temporary blockages down there in your calf or in your foot. So you always have to be very, very careful and mitigate those risk factors when it comes to PAD, because every little thing seems to, impact it.
Well,
I found that.
this is in my good. It's in my good leg. It's in my left leg that I
Yeah.
didn't have pad in. But I'll never smoke again. I'm now 5 weeks smoke free.
Yay!
And I don't even,
Good
you know
job.
what? I'm not even craving one. It's mad. I used to smoke 40, 50 a day, one after the other. I'm not even craving a cigarette anymore. It's
I am
Wow.
so proud of you.
I don't know why. Maybe it's in my head now. Don't have a cigarette or you lose your leg. So that's in my head.
Yeah.
But it's my left leg that started to hurt, and my last Doppler on my left leg was 1.2, but it's starting to hurt, not as much as my right, The right one still really hurts when I walk. So I am going to, I tried all last week to get into the doctors. No appointments. Not even a phone appointment. So I'll try again this week just to ask them if they can do a Doppler on me.
Yeah.
Because I'm
Yeah,
walking loads at the moment because I've got 3 dogs to walk.
for you.
My dad's dogs. Yeah, my dad, he went to the London Royal Free Hospital 2 weeks on Friday. He's got cancer and he had his kidney out. So I've got his dogs. He's home now, but they didn't get all the cancer, so he has to go back in for laser. So I've got his 2 dogs, but one of them's a nightmare.
Well, there is
Right.
a study that shows that you walk 22 minutes more each day if you do have a dog. So dogs
Yeah.
are great. We do it. Pause for PAD, PAWS, pause for PAD.
Yeah. Well, today I went on a walking pad for 30 minutes, and then I walked Frank, the yapper, round the block, 20 minutes. Then I come back and took Reggie, 20 minutes, and then I come back and took Elmo, but Elmo's old, so he can't walk that far. So yeah, so that's me every day. Oh, and then I
Wow.
walked to Waitrose, which is 15 minutes away and back again.
Good for
Yeah,
you.
walked a lot today. But
So
I'm
you're
just a bit
still,
worried about my
just
left
check your
leg.
feet. Check your feet, check the temperature, of your feet. Sometimes you can tell if one foot's colder than the other, if there's, whether it's vascular or whether it might have been from the slip that you did. And that's a way that you can kind of, check. We have Kevin Morgan, who is he co-hosts our Collateral Nation podcast, and he's also a pathologist, and he talks about getting an oximeter and checking the pressure, the toe pressure in your toes as well. It's not 100%, but at least if you know what it normally is and you can get a baseline, then it becomes a really great tool, adjunctive tool, to help you be able to manage things a little bit at home in between appointments.
Hmm.
Yeah,
I
I
found
just
that
don't
when
I
my
haven't
foot
got
when
it in my left leg.
Hmm.
That,
I find that when my feet go cold, I can actually feel it. I can feel it coming on, to be honest. And it's both feet as well. So I think that last time I went to go and see my podiatrist, she walked in straight away. It was my first consultation with her, actually. And she just walked in, looked at my feet, and she said, "You've got Raynaud's." Straight away. She just took one look at my feet. And she was like, you've got some sort of Raynaud's. She said, you've got little chilblains at the end of your toes and stuff like that. So that's where the coldness is affecting your feet. So I'm just putting it down to that. I've got an appointment with the podiatrist next Tuesday, actually. I'm quite looking forward to seeing her because she's from the UK. And I brought her some cream that you can only get from the UK as well, which is quite good. But she's going to repeat my ABI, and she's going to do a toe TBI as well, because I didn't have I didn't have a toe one done when I got tested in the UK.
Yeah.
So I'm looking forward to seeing what the results are of that as well. So
Yeah,
my
definitely.
toe was 0 when I got diagnosed with CLI. My toe was 0. It's now 0.48.
yeah,
So that's
Gone
actually,
up.
it's still down below where you want it to be, but it's so much better than it was since you did quit smoking and your vessels are not spasming, like they were. It doesn't mean there isn't any sort of plaque in there. It sounds like there probably is, as you said, your doctors have told you, but by the same token, it's great the impact that smoking cessation has had on improving your prognosis and where you're at right now, and in hearing how much you're walking, which is incredible. And how much, in terms of, I think the group you have mentioned and having the support has really played a role in helping you to quit smoking and to walk, walk, walk.
Mike. I
It's
always
just
phone
my,
Mike.
I've been talking to Tracy since she was diagnosed. I was one of the first people to reach out to Tracy, so I do talk to her at least once a week we keep in touch with each other and kind of spur each other on. She helps me. I know that she says that I help her a lot, but she does help me as well.
I
So
love it. I love it. Well,
I'm really sorry, but I'm gonna have to call it a day in a minute because I've got to take the dogs out before we go out
I
for
gotta
dinner.
go.
I've
Go
got
meet my
to
dad.
take my dogs
for
out
some
now.
lunch. And I got to go play with my dogs. So pause for Pad. And it was really great. I love this. And I think we should do this every week. So hopefully people will like this video. Tell us that you want us to do this more and more and more. Sometimes we'll have physicians or clinicians that join us from the UK to help answer our questions. But in the meantime, it's really great to have a forum like this to raise our voices and to share the experiences publicly so that people understand what it's like, the PAD, the lived experience, you know, for patients in the UK. So thanks everyone for joining us. Thank you, Mike, for your being such a good sport and co-hosting this with me. It's great. And thank you, Tracy, for being here. And thank you to Josh, our YouTube producer, for being flexible and adapting and launching us live on YouTube.
And thanks to Alan, even though that he's not here, just in case he watches the video back.
I tried.